one thing that the pathologists do have is histology, and whether it's squamous or non-squamous. What are your views about level of enthusiasm or data to support, you know, a difference in the mandate or desire for molecular testing for squamous or non-squamous, trying to be both comprehensive and efficient, parsimonious? Riyaz, can you take that first?
So until fairly recently, PD-L1 testing is pretty much all we would do for a squamous patient. And then if I met that patient in clinic and they turned out to be the occasional non-smoker, then I would personally get back to my pathology lab and ask them to do a full genomic screen. And then we would routinely do full genomics on non-squamous. But I think the KRAS thing has really made me rethink that. So sotorasib and G12C and picking up all those patients. So I mean, we haven't switched to doing full molecular testing in squames yet, but I'm really having a hard think about it.
And there's no kind of healthcare-wide policy on that.
No. I mean, we don't have to. I don't have to fight with individual insurers. I think as a nation, we have to fight with the central commissioning system, and once that is approved, then it's you know, uniform in theory.
And Estelle?
Yeah, I would add that, you know, as we're doing more next generation sequencing and really understanding commutations and a lot of different things that happen when these tumors present, obviously we know that when patients have resected disease, that tumor may be very different than when they have metastatic disease where KRAS G12C and MET exon 14 skip mutation can have an option for squamous. But I have found it useful that when we have NGS analysis on patients with squamous, and we found commutations like KRAS, STK11, KEAP1, it kind of raises the concern of follow-up for that patient. So I have kind of take that into part of the story of that patient. But I think we know that there's some mixed histology, so we don't really try to base the test on the histology since we can find some EGFR mutations on tumors that have mixed histology. So we are trying to not base it on histology, just really understand the pathology and the genomics for that patient.
Okay, great. And Narjust, I see you joined again. I hope.
Sorry, I'm in like the northern part of the state, and it looks like the internet is not great here.
Fair enough. Well, we were just, you know, basically following up on, you had mentioned in your answer that there's differences based on whether it's stage 1 or 2 and 3. If you can speak, I didn't catch it that clearly. Maybe you can speak to both your personal level of enthusiasm or disinclination for broad testing based on stage, and also whether histology and squamous versus non-squamous is much of a factor to you, or is it a broad, everyone gets everything?
Well, I think to tend to be a little more histology. Can you hear me, Jack? Better?
Very well.
So third time is a charm. I think we divide between adenocarcinoma and squamous, in part because how we're gonna get these tests also covered by insurance. Because for early stage has been a little bit more challenging to get it covered, or patients have big copays and there is no option of doing plasma because these are early stages. So that helps me differentiate if the patient will go into the billable NGS or we go into a research NGS protocol, that those patients won't get charged. It's under a research protocol. So, you know, besides the histology, it's also the reimbursement. It plays a role in these cases. We also have patients that come as second opinion, so they already come with some genetic testing in some cases. But the main reason why I do it is to determine if they are candidates for trials and start planning ahead of time. Because I would hate to have a patient that has an EGFR mutation and go in an adjuvant immunotherapy trial. I know Power 0110 included those patients and the approval includes them, but we know that immunotherapy is not great for those patients. So I don't want to go in the wrong trial. I also like to prepare things ahead of time. So I don't preclude the possibility of the patient of going in an adjuvant trial. For example, 38-year-old patient I have, we did NGS and she has a RET mutation. So I'm able to like pre-screen her for the trial as she gets ready for surgery, and we all work together so nothing is done to exclude her from the trial. Because I have been in the case in which the patient comes after the surgery and you're like, oh, but we needed to do all of this, and then the patient cannot enroll in the trial. So just planning like 3 months ahead of time, NGS allows me to do that.